Okay, I think everybody is present. Thank you. Welcome, Teresa Latham. My name is Marleen van Baak. I will chair this session as the pro-rector. And on the screen you see your supervisory team and the degree committee. It's time to start, so hereby I open this academic ceremony in which, let's see, Teresa Smith Latham will defend the academic thesis Implementing Novel Strategies to Promote Informatics Research and Education, Building Capacity for Sickle Cell Disease Diagnosis, Management and Treatment in Low-Resource Settings. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear distinguished members of the Corona, my name is Teresa Latham, and today I will present my thesis entitled Inspire, Building Capacity for Sickle Cell Disease Diagnosis, Management, and Treatment in Resource-Limited Settings. For many, sickle cell anemia is the worst disease that you have never heard of. I want to invite you on a journey, one that spans continents, health systems, and the lives of children born with sickle cell anemia. This work, called Inspire, focuses on building the capacity needed to diagnose, manage, and treat sickle cell anemia in places where resources are limited, but the need is immense. Sickle cell anemia is one of the most common and severe genetic diseases in the world. Every year, about 500,000 babies are born with it, most of them in Africa. Many of these children face repeated pain crises, infections, strokes, and organ damage. And tragically, many die young, not because we lack the treatments, but because health systems lack the tools, training, and infrastructure to deliver them. Sickle cell anemia is prevalent in sub-Saharan Africa due to the adaptive survival advantage conferred by having sickle cell trait, which is one copy of the sickle cell gene. The image on the bottom left of the slide shows the overlapping prevalence of sickle cell anemia, which is 2 copies of the gene, and malaria in sub-Saharan Africa. The paintings on the bottom right are by Hertz Nazaire, who recently died from sickle cell anemia, and they depict the crushing burden and intense pain associated with a sickle cell crisis. In high-resource settings, children with sickle cell anemia routinely receive early diagnosis, stroke screening through transcranial Doppler or TCD ultrasonography, hydroxyurea treatment, and specialized care. However, in many resource-limited settings, these same tools are scarce, inaccessible, or unknown. This is not a failure of science. It is a failure of systems, infrastructure, and global equity. The aim of this thesis is to fill that gap by producing research results that inform best practices for capacity building in resource-limited settings with a focus on informatics, research, and provider education. The aim of this PhD was to understand how we can build sustainable capacity for sickle cell care. This means several things. First, understanding where the gaps are. What do providers know? What tools do they have? What stands in their way? Identifying what works. What strategies help build sustainable capacity? Demonstrating feasibility. Can stroke screening and hydroxyurea treatment be implemented safely and sustainably in low resource settings? And further, exploring comorbidities like HIV, where systemic weaknesses become even more visible in light of increased mortality and limited healthcare infrastructure. These objectives led to multiple studies, literature reviews, qualitative studies, clinical trials, and policy analyses. Together, they form a comprehensive picture of what's working, what's missing, and what's possible. When we talk about capacity building, we are not simply talking about training. It is about transferring knowledge and tools in a way that respects and responds to local realities. In global health governance, we recognize that improving care for sickle cell anemia is not just a scientific challenge, it is a moral imperative. Sustainable change only happens when local stakeholders are engaged and empowered to lead. Having set the stage with these core concepts, which provide a common theoretical thread among my research objectives and results, I will now describe each of the objectives in more detail and share the results associated with those objectives. My first objective had two components, and the first was addressed through a narrative literature review of 37 peer-reviewed manuscripts. Analysis resulted in 4 primary themes, including the identification of primary stroke as a leading cause of permanent disability and death in this population. The implication is clear that we must transition care from reactive symptom management to preventative screening using TCD ultrasonography and hydroxyurea at maximum tolerated dose, or MTD, in a way that is both locally feasible and sustainable. Building on the literature review results, we then sought to better understand the knowledge gaps from the perspective of the healthcare providers themselves. Our qualitative study, entitled Stretch 2, involved semi-structured interviews and survey administration among 18 healthcare providers from 6 countries in Africa and the Caribbean. 65% of providers surveyed reported that they felt under-equipped to manage hydroxyurea dose escalation, and participants highlighted infrastructure fragility and significant barriers to training uptake in these regions. We found that healthcare providers were deeply committed to improving care, but many lacked the access to training, particularly in stroke screening and hydroxyurea management. Telementoring programs prove attractive and effective in this setting, showing that knowledge transfer doesn't require expensive infrastructure, just connection and commitment. Objective 2 focused on outcomes in healthcare system infrastructure and serves as a vital bridge between poor clinical outcomes, death, and broader healthcare system-driven factors for sustainable capacity building. The work leverages technology and informatics in a large Ugandan database of children for both sickle cell anemia and HIV to investigate their epidemiology and clinical course, while also exploring health system and e-health infrastructure barriers to patient identification, follow-up, and continuity of care in early childhood. This research was a retrospective case control study, which utilized a novel database algorithm to identify age-matched controls from each category within the closest geographical region to improve the likelihood of successful contact. The search project, both results found that children born with both sickle cell anemia and HIV face higher mortality. In addition to this stark survival disparity among children with dual disease burden, the search project identified several health system gaps, including a lack of antiretroviral therapy and hydroxyurea in the dually diagnosed group, and major challenges in participant tracing and follow-up due to e-health infrastructure limitations. We then move into clinical validation through the SPHERE trial in Mwanza, Tanzania, and the SACRED trial in Santo Domingo, Dominican Republic, which together make a powerful case for linking technology and knowledge transfer to improve patient outcomes in high-risk populations. These prospective trials used a standardized TCD protocol and hydroxyurea escalated to MTD in a group of children with sickle cell anemia at elevated risk for stroke. Both trials showed a statistically significant reduction in TCD velocities, confirming the safety and efficacy of this approach. The use of a digital dosing tool was a facilitator of provider adherence to dose escalation protocols in both trial contexts. SPHERE and SACRED collectively demonstrated that capacity building and clinical research can work as symbiotic partners, and that clinical outcomes can improve significantly as a result. We also learned that equitable partnerships between high-resource and low-resource countries can transform care. When these partnerships focus on training, infrastructure, and shared leadership, they create lasting change, not dependency. The Stretch 1 project included semi-structured interviews with thematic analysis, which found that success relied heavily on a train-the-trainer model rather than one-off external interventions, and that stakeholder engagement, particularly with ministries of health, was cited as a key driver of sustainability. And lastly, that task shifting to use the non-physician examiners to help ensure long-term cost effectiveness and resource utilization. The core of my research centers on the INSPIRE model, a framework designed to bridge the gap between clinical and sustainable practice in resource-limited settings. This model addresses three key areas: informatics, research, and education, and it is flexible and rooted in several core findings from my research. Clinical feasibility and the potential for improvement. Despite the high rates of morbidity and mortality associated with sickle cell anemia, there are substantial untapped opportunities to improve patient outcomes at all life stages. Leveraging local strengths. Sustainable progress depends on identifying and building upon the existing resilience and systemic strengths within resource-limited settings. The power of knowledge transfer. Capacity building is most effective when it utilizes North-South partnerships to facilitate the transfer of technology, informatics, and clinical expertise. Scalable frameworks for change are key. Success requires a focus on a triple threat intervention, those that are feasible to implement, sustainable over time, and scalable across different health systems. And lastly, systemic strengthening. Improving outcomes acts as a catalyst for overall health system strengthening in underserved regions. To make this sustainable, I recommend 4 key areas of policy engagement. The first being regional manufacturing to produce hydroxyurea locally with engagement with ministries of health. This will both mitigate the volatility of international shipping and foreign exchange while simultaneously improving clinical outcomes and stimulating local pharmaceutical economies. National integration. Hydroxyurea must be included in national medical stores as a standard of care, moving beyond pilot and research projects to a national mandate, which will improve the consistency of stock in healthcare facilities across regions. Institutional support. North-South partnerships with Ministry of Health engagement for provider education, including certification, and creating a platform that supports co-creation of training and clinical guidelines, which are locally appropriate and shifting towards a model of local autonomy, expertise, and ultimately South-South partnerships between countries within sub-Saharan Africa. Digital infrastructure. Implementation of electronic systems to follow patients across their lifespan, avoiding data silos and allowing for data collection at the population level. In the interest of academic rigor, it is important to note the boundaries of this work, which notably included data collection challenges, geographic content and scope challenges, and sample constraints among the qualitative projects. We stand at a moment where the science is clear, the tools exist, and the need is urgent. No child should die from a disease that we already know how to treat. Capacity building is not charity, it is equality, and child health is a basic human right. The INSPIRE model rejects the concept of medical colonialism and in place proposes a shift towards social constructivist learning, where knowledge is not given by the North to the South, but co-created within the local context. As Nelson Mandela wrote, "After climbing a great hill, one only finds that there are more hills to climb." The hill we are climbing in this context is the survival gap for children with sickle cell anemia in sub-Saharan Africa, who still face a life expectancy significantly lower than that of children in the United States and Europe. The true measure of our success will not be found in the publication of this thesis, but in the creation of self-sufficient data-driven systems where local providers are the experts and leaders. I am calling for an end to long-term reliance on external aid and a beginning to sustainable local intellectual autonomy. Every child, regardless of the continent on which they are born, deserves a future free from the devastating morbidity of sickle cell anemia. This thesis represents not only a scientific body of work, but a series of lived experiences which demonstrate the profound transformative power of investment in systems and individuals to shift toward a future reality of accessible, life-saving care for sickle cell anemia. The Inspire thesis would not have been possible without extraordinary mentorship and collaborators, clinicians, researchers, families, and children across multiple systems and countries. I am humbled by and grateful for your support and collaboration. And lastly, if you're curious about the origins of my tree art, under this massive tree in Atutur, Uganda, this is where Dr. Sarah Iragu holds her sickle cell clinic for over 1,000 children, which is collectively amazing and inspiring. Thank you.
Thank you, Teresa Latham, for your presentation. It's now time to start with the opposition, and the opposition will be opened by the chair of the assessment committee of your thesis, Professor Ten Kate, Professor of Clinical Thrombosis and Hemostasis at Maastricht University.
Thank you very much, Pro-Rector, dear candidate. It's a great pleasure to participate in this session. I'd like to congratulate you with the accomplishment of the thesis and also with the very clear introduction that you gave, and I fully support your call to action. It's a very important topic, and I want to share the congratulations with the supervisory team. It's a rare disease indeed in some countries like the Netherlands, although I very well remember the days when I was a resident in a community hospital in Amsterdam, and I frequently admitted patients with a sickle cell crisis, and it made a lasting impression. The pain and the fact that we couldn't offer very much on top of morphine and blood transfusion. So I'm very encouraged by the data that you present and by the work in this thesis. Having said that, I have a couple of questions I would like to ask you, and the first question relates to the SPHERE trial that you published so nicely in the Lancet Hematology, and that starts at page 135. And I had some practical questions, and it may be slightly out of the scope of the thesis as such, but I was wondering, you give, or you're testing basically the feasibility and the impact of escalated doses of Hydrea in TCD selected patients. And I noticed, and that's also what you reported in the discussion, that taking this medication by children is not a trivial matter. And oftentimes, I guess you may have to process to allow capsules to be chewed, and even to distribute or dispense the medication of a daily dose over a week, period of a week. And again, it's not a question that may be in the front of your mind, but I was curious if you had any idea about the adherence to medication in these young children, and whether the pharmacokinetics, how much that is influenced by the different ways by which these tablets are ingested. Could you perhaps tell me or speculate a bit on these practical matters, how this worked, and whether that might explain the variation in responses that you observed in page 157. Maybe you can address these points.
Thank you, highly esteemed opponent, for this question. The SPHERE trial treated a group of children who were at elevated risk for stroke based on their transcranial Doppler findings. And as I report, the children took hydroxyurea escalated to maximum tolerated dose. They were able to escalate after 8 weeks of treatment at fixed dose. And in that setting in Tanzania where we ran the SPHERE trial, there was only access, and still is, to 500 milligram capsules of hydroxyurea. This is representative of the experience of many countries in sub-Saharan Africa. And we treated, these were fairly young children, so many of them took a dose, particularly sometimes 4 days a week, 5 days a week, a different dose on the weekends. And we did track their outcomes. We found them to be highly adherent in general to both the protocol schedule assessments as well as to hydroxyurea therapy. This was something that we followed in their laboratory values over time while they participated in the trial. With regard to the pharmacokinetics, so the pharmacokinetics of hydroxyurea, we know that the drug is eliminated within 2 to 3 hours on average. However, the treatment effects themselves, the pharmacodynamics of hydroxyurea, last much longer than that. And so that is why we believe that the multi-day dosing, every other day dosing, which is something that allows hydroxyurea to be more accessible to populations which have limited access to 100 milligram capsules, liquid, things like that, is a very attractive option, since it seems to confer the same treatment benefit and protection against stroke than the more specific dose increments, which might be smaller. We saw that to be fairly consistent. And overall, it was a very adherent group. They were, I will note, on the younger side. So as children age into adolescence, we become more concerned about hydroxyurea adherence and need to begin to assess and employ different strategies to support that as they become responsible for their own medication over time.
Thank you very much. This is a very clear answer. So this also calls, I guess, for local production of hydroxyurea in different dose tablets and not having to process these larger capsules, as you suggested.
Thank you for the question. That's possible, but I actually believe that from what we've learned, that manufacturing of 500 milligram capsules, if it could occur within countries on the sub-Saharan African continent, would be such a major step forward that if providers are given tools and education to manage multi-day dosing, that it would be a feasible and attractive option in the absence of a more specific dosing regimen with smaller increments, as you state. Certainly precision would be the ideal scenario, but working in resource-limited settings, we know that ideal is not always what we experience in every case. And so problem solving and using the resources available to us to have a dosing algorithm that is equally protective and confers clinical benefit is still a major step forward for this population.
Thank you very much. The second and last question from my side. Could you read perhaps proposition number 4 about the North-South partnerships?
I would be glad to. Thank you.
Ask that to the para-nymphen, but now I have to ask you. Perhaps you can read it to us.
Thank you, esteemed opponent. North-South partnerships are a key driver of improving outcomes and capacity in resource-limited settings.
Okay, yeah, I was curious what exactly you envision with North-South partnerships. Could you embark a little bit on what you
Thank you for the question. Yes, so North-South partnerships in this context, I'm referring to academic and research-based partnerships between academic centers in high-resource settings and healthcare facilities and or academic centers in low-resource settings. So the transcranial Doppler project is a great example of how tools and technology that are commonplace and highly used in the United States and Europe are not available as frequently in resource-limited settings, but we can't make the assumption that they will work equally well with the same type of training tools processes that are used in the United States and Europe. So partnering between North-South groups for the purpose of transferring knowledge, but doing so in a way that involves understanding local context and not simply making assumptions about what works best for us must likely work for them, will both allow for more sustainable change implementation over time and also create in the longer term a situation where South-South partnerships and the co-creation of clinical guidelines, training and tools between countries within sub-Saharan Africa will be possible.
Thank you very much for this very clear answer, and I'm very happy with the answers, and I wish you all sorts of success with these ambitious programs. I give the word back to the prorector.
Thank you.
Thank you, Professor Ten Kate. The opposition will be continued by Professor Pavlova, Professor of Health Economics and Equity at Maastricht University.
Dear candidate, my congratulations to you and to your supervisory team for this valuable dissertation. Your dissertation makes a clear contribution to academic knowledge and to practice on improving outcomes for people with sickle cell anemia. You present evidence on important regions which have high burden of disease, but also limited resources to address the problem and to deal with such health crisis. Most importantly, the dissertation employs a multidisciplinary perspective, which is an intersection between informatics, clinical research, and provider education, and that shows high originality of your thinking and depth in your research. I would like to discuss with you exactly this multidisciplinary approach in more details. Especially, let's look at the end, the last chapter, the discussion chapter, where you put forward the INSPIRE conceptual model, the INSPIRE framework, as an integrated approach to capacity building for sickle cell anemia in a resource-limited setting. I wonder how and to what extent the evidence generated across your different studies support the validity of this framework. For example, your dissertation includes different research approaches from different disciplines like observational, epidemiology, clinical trials, qualitative studies, so many diverse approaches, different disciplines. How and to what extent do these very different methodologies inform the structure and components of the model? Why they good support in validating the model? Why just 3 pillars? Why is informatics a separate pillar and not part of research and education? So I had all these kind of thoughts looking at the model, and I'll be happy to hear your justification on this.
Thank you, highly esteemed opponent, for this question. The 3 pillars, research, informatics, and education, are the primary main areas thematically that this model relies on. And first, to answer the last part of your question, informatics is set outside of the research pillar because informatics is inclusive both of informatics, which we utilize within the context of our trials, as well as the broader public health and health system infrastructure components of informatics more generally. So the projects utilize databases within the context of clinical trials, but also, for example, the search project looked at informatics gaps in the e-health infrastructure more broadly. And this is a common challenge across resource-limited settings in sub-Saharan Africa. In 2017, the Ugandan Ministry of Health published an e-health infrastructure policy guidance documenting the gaps which existed and issuing a call to help through the health system to help work in collaboration to improve those gaps. And that is one example of acknowledging the gaps which exist from an informatics perspective, which truly limit the ability of ministries of health to understand the health of their population over the lifespan. And so I felt that that needed to stand alone as its own pillar, because while it is so important within the context of our trials, we would be losing out on a key element of healthcare system infrastructure benefit if it didn't stand alone as its own. From the validity perspective, so my model that I've created is complex, it's multi-layered, and given that treating sickle cell anemia is so varied with regard to what's available within multiple clinical settings across sub-Saharan Africa, I feel that it's both functional and contextual and does possess a high level of ecological validity in that we have used it across multiple settings, informatics research, and then ultimately educating healthcare providers and transferring that knowledge are the core components to all aspects of the studies that are reflected in my thesis. However, that is not to say that it does not have opportunity for further assessment of its validity. I hope that the INSPIRE model is one that can be used more generally and translated into use in other sickle cell anemia settings, but also for capacity building within resource limited settings specific to other non-communicable diseases and other trials to just further document the validity, which is just initially documented here within my thesis.
Thank you for this clarification. Yeah, I think I understand now better the justification of the model. But I also wonder how generalizable is also the model. So a good model is not only valid and supported with evidence, but also generalizable. You have used data from different parts of the world. To what extent are your findings and also the INSPIRE model transferable to other resource-limited settings that were not covered in your research? What other contextual factor might limit the applicability? You already mentioned informatics, how feasible is informatics in resource-limited setting, although we recognize it's important, but how feasible it is? Please.
Thank you for the question. From a generalizability perspective, I believe that the model is highly generalizable in that its functionality is not overly complex. It focuses on key areas which can be addressed within the concept of sickle cell anemia and beyond. I think it's a model that allows for structuring, training, and improvement in systems in a way that is both feasible and sets the stage for measurability. I think it would be very relevant scaling beyond the TCD example to other healthcare tools and assessments within sickle cell, including cerebral oxygenation, ultrasound, the use of multidisciplinary medical providers within healthcare facilities, which is something that the more detailed aspects of the model describe, allows for and recommend task shifting approaches with which help to make the knowledge more sustainable and more feasible within multiple provider types, not limiting knowledge to one specific individual or individuals. I believe that's something that as capacity is built within these settings, maintaining a focus on the generalizability of this type of approach will help it be more sustainable over time. Lastly, I think that additional research would be very helpful to prove that. I think it's an opportunity for our group and hopefully others to take the model and try it in other settings and perhaps offer academic feedback as to how generalizable it truly is. Speaking to limitations, some of the limitations that I think are most relevant, but also can be addressed, are first linguistic. We experienced through some of our early work needing to develop methods for interacting with partners and groups that don't speak English and making sure that we had the linguistic capacities within our groups to bridge that gap, and ultimately to creating local leaders within the settings who are then responsible for training those around them and really implementing local expertise moved the needle significantly when it came to the success of training in these various paradigms. So that's one of the things. And then also something as simple as access to technology and documentation of processes, not making the assumption that the processes that we've developed here in a high resource setting will transfer directly without significant revision and input from local experts is something that it's both a limitation, but something that if it's appropriately anticipated can certainly be mitigated.
Thank you. Let's dive a little bit deeper into this discussion. Exactly what you mentioned is linked to my final question, and that is about the future use of the model. I was wondering whether the model can be also used to evaluate to what extent the health system capacity has been improved. Do you see this kind of application of the model? Yes, please.
Could you try to give a short answer because of the time?
Sure. Thank you for the question. Yes, I do believe that it can be applicable and scaled. I think that there are various opportunities for moving it beyond transcranial Doppler, and that several research questions could be asked that could help us better assess whether it's useful as more of an implementation science model. I think there is great opportunity for that, I hope.
Thank you. I give back the word to the prorector.
Thank you, Professor Pavlova. Then it's the turn of Professor Chilolo, Professor of Pediatrics and Hematology from the official University of Mai, difficult name, in Kinshasa, Democratic Republic of Congo.
Thank you very much for this opportunity to discuss with the candidate. I congratulate for this great job, and I appreciate the fact that she worked on disease, which is neglected disease in many of the sub-Saharan African countries. And I think that this work will contribute to the advocacy for the management of sickle cell disease. Congratulations for that. I was very interested on the best practices for training and capacity building you develop in your study, in your works. And I would like also to put some questions. The first one will concern the South-South partnership, and not only the North-South partnership. For concerning the South-South partnership, I would like to know, how do you think that your work can help to reduce the bridge that we observe between the Francophone countries and the Anglophone countries in the sub-Saharan African areas? Over to you.
Thank you, highly esteemed opponent, for this question. The ultimate goal of South-to-South partnerships is such an important one. We have built the foundation for knowledge transfer, and ultimately the ideal scenario will be countries within sub-Saharan Africa working together with intellectual autonomy and some input from the high resource settings. The linguistic challenge is one we have experienced, and yet is one that, as I mentioned, can absolutely be mitigated with appropriate planning and troubleshooting and putting in place local leaders who can bridge that language gap. I think the language gap can never be one that we say, oh, two countries can't work together because they don't speak the same language. I don't believe that we would have been successful in any of our work if we had believed that early on. And so a belief in doing that which is challenging and coming up with strategies to mitigate those challenges is absolutely feasible. And Francophone Africa, which is affected and has some of the largest population of children affected by sickle cell disease must be included in that dialogue. To fail to do so would be a failure of everyone who's been involved in this effort to date. So I think it's an openness to managing those, putting forth communication strategies, and then building leaders, more leaders within your local context where you've already done so much work in that space.
Thank you very much. And how do you reduce the risk of drain brain?
Thank you. Thank you for the question. So brain drain, how do we reduce the risk of doctors that we've trained leaving for other settings? It's a very real challenge. It's one that we all strive when working in a model like the Inspire model, that we are creating capacity in places where the people will continue to remain and offer care to patients. There is an attractive pathway to leave for higher resource settings. I think that's something that we have to expect and plan for. And that is why when we discuss education of the workforce, we do that in an inclusive manner that is focused on multiple physicians, medical officers at various levels, and also includes nurses and other skilled medical providers, community caregivers who provide care for patients, so that if one individual chooses to leave and go to a different setting, either temporarily for education or permanently, that the investment we've made overall in transferring that knowledge is not lost.
Thank you. So now the last question. Do you think that there are some international institutions that can contribute to the dissemination of these different tools you are developing, for example, for the TCD training? And sub-question, the last one, is what about the sustainability of this TCD training, for example?
Thank you for the question. We're very proud of the recently published TCD training methodology in Stretch 1, and the next step towards generalizability must be to further scale that. And outside of the clinical trial context, WHO, Médecins Sans Frontières, other groups like that would be attractive partners who I would hope would be willing to help to take some of those tools, processes, and frameworks, something specific to TCD, but also very applicable to other tools like abdominal ultrasound, cerebral oximetry, things like that, that require that skill, and make it available to other providers. I would argue hydroxyurea dosing tools would fit into that context as well.
Thank you very much. Dear Rector, it's all for me. Thank you.
Thank you very much, Professor Thiololo. Then the opposition will be continued by Professor Williams, Professor of Hemoglobulinopathy Research at Imperial College in London.
Thank you very much. Thank you to the defendant for a lovely presentation. I want to join all the examiners in congratulating you for your a great thesis, and I think I was particularly impressed by its interdisciplinarity and how many different areas it covered in terms of clinical and sociological and other areas. So very well done. I have a few questions. The first, I guess, will follow up a little bit on what the Professor Thiololo just asked about sustainability, but not just sustainability, but feasibility in the context of introducing this TCD training outside of a research context. So I think you will all have to accept that the context in which you set this up was quite in a rarefied environment with relatively small numbers and a lot of oversight from outside. How feasible do you think it would really be to set this up in a real world situation with very limited support that you've been able to provide from the States?
Thank you, highly esteemed opponent, for the question. I do think it is feasible to transfer this TCD training process into the clinical setting, I think there will be some specificity lost. As you said, we've provided a great deal of oversight with regard to central reviews, things like that, making sure that per the clinical trial protocol, we were able to publish results that were valid. However, what we learned from that was how important TCD is as a screening tool, particularly in settings where not every child can have access to hydroxyurea. And so finding those at risk for stroke and mitigating that early to avoid long-term damage is such an important tool and approach. I think that the task shifting to medical officers, nurses, finding individuals who have an aptitude for it. One of the things we learned through many years of training in TCD is that there's not a one single title or role or training background that lends itself well to it. So being able to document a set of processes for screening attractive candidates to learn it, providing training, and then some level of oversight, I think would be something we could provide to health centers. And then secondly, if organizations, health systems, external partners could provide the technology has improved so significantly in the last 10 years that what is available now as a screening tool is something that multiple providers within health facility contexts could learn, and I believe perform the screening tool in a safe and feasible way.
Okay, great. You've mentioned task shifting quite a lot in both in the presentation and in your response to some of the other questions. So I get the task. I think it's a very interesting concept that you're shifting the technological training for TCD to non-physicians. Can you think of any other areas in the care of children with sickle cell disease in these resource-limited settings where task shifting might also be helpful?
Thank you.
Who would you shift to?
Thank you for the question. Yes, I think there's a variety of areas where task shifting is appropriate. I've mentioned things like ultrasound, cerebral oxygenation. However, also assessing how patients are doing from a mental health perspective, assessing their adherence to hydroxyurea is a great example of task shifting, because one thing that we know is if the physician asks the child how they're doing and if they're taking their medication, that they'll say yes. And if we can empower multiple providers who interact with a child and their family throughout a visit and between visits to ask about hydroxyurea, to inquire about how they're doing, other social and emotional challenges happening in their lives, that's a task that should not live solely with the provider, and is through collectively getting that information and then communicating as a team, the team can have a better sense of how a child is actually doing on their medication, because we know that putting the medication in their hands does not equate to putting it in their mouths. And if they don't take it on a regular basis, that their clinical risk will increase significantly. So additional training on dosing and adherence to me is another major area where task shifting would both improve the sustainability of the healthcare workforce, but also empower that workforce to improve outcomes for the patients.
Okay, lovely. Thanks very much. That's very clear. So I just wonder whether you want to reflect on. So you did a lot of this work, started it quite a few years ago when it's true to say that hydroxyurea was fairly limited in its distribution in Africa. But I think in the work that you're doing now on other studies, I think you will acknowledge that it's becoming increasingly available in a number of places, and in some countries, including where I work in Uganda, it's now moving to standard of care. So I wonder now, moving forward from where you started, whether you would still think that the emphasis on TCD training is necessary, or whether in a new world where you emphasize the making all children making hydroxyurea available to all children at a maximum dose that you can, given the constraints of the dosing schedule. Do you think there's still, in that circumstance, you think there's still a central role for TCD, given that it's quite complicated and involves a lot of technological support, etc.?
Thank you for the question. I would argue that it does still have a role. I think that the scenario of hydroxyurea being widely available it's the goal that we all have, and yet we do know that patients don't always consistently take it, and being able to identify the patients who continue to be at risk either due to a lower dose, due to adherence issues, things like that. I don't think that TCD would stand alone as the only assessment that would be indicative of a lack of adherence or elevated stroke risk, but having the ability to screen within a clinic, particularly in the cases of inconsistent hydroxyurea supply or adherence issues, it's a skill that I think would be still valuable to impart within a clinical team.
Okay, fair enough. I think I'll leave it there, Pro-Rector, and hand it back to you.
There's 2 more minutes, but
Oh, if I've still got if I've got another minute, then I'll. I was just following up on the Sacred and the Sphere trials, and you were conducting these trials in really very resource-constrained situations. Can you explain what commonly misunderstood aspects of performing clinical trials in that sort of place might involve?
Thank you for this question. I think the most common misconception is that it cannot be done well, and that the standards of research should be somehow changed or lowered and in resource-limited settings. And I would argue that that the opposite is true, and that we are responsible to perform good, high-quality, valid, ethical, and safe clinical research, no matter where we are in the world. And I think I've heard many people say things like the patients just won't come for their visits. You won't be able to collect any data. And in Sphere, we treated eventually 150 children. In Sacred, we treated 74 children. Both trials had higher than 95% visit adherence rates and 92% adherence rates in window, meaning that the data that we collected were time relevant based on treatment exposure. We were able to describe the rates of risk, the rates of clinical events, and all of which is so valuable. And if that research was not performed in the settings most affected by the disease, I think the findings would be less relevant and less meaningful.
Okay, that's lovely. Thank you very much. I'll hand you back.
thank you, Professor Williams. We now come to the last opponent. That's Dr. Brouwer, Assistant Professor and Director of She Collaborates at Maastricht University.
Thank you, Pro-Rector. Dear candidate, many congratulations to you and your team for pulling together this vast body of work that I think already has and definitely will contribute to the health and well-being of often neglected parts of our global population. You combine trials and training needs analysis and capacity building practices, which shows not only your commitment to international health, but also, I think, your own research capacity development over the past years. I work here in Maastricht at She Collaborates, the School of Health Professions Education, where a lot of my work involves training and capacity building in health professions education in the Global South. Therefore, I am particularly keen to discuss a bit further on chapters 3 and 6 with you, which are about training needs and implementation of capacity development. In chapter 3, you aim to understand training needs based on a literature search and a series of interviews. And I was interested in the results section of that interview study. It's on page 89 in your thesis, in a table 2, where you identify 4 themes around clinician experience and demographics, around location and context, around resources and treatment availability. And I was wondering if you could start by explaining me how these 4 themes relate to training needs, how you maybe approach the data analysis of these interviews that you did, and how you arrived to these themes to explain training needs.
Thank you, highly esteemed opponent, for the question. So the Stretch 2 project, which was a qualitative assessment of healthcare providers and their educational needs across resource-limited settings, we looked at a diverse group of participants, and when we aimed to analyze the data, we used the reflective thematic analysis approach, and in doing so, we aimed to identify and generate themes, but not to develop a theoretical model in and of itself. And so in doing so, we were really trying to understand both the semantic and the latent meanings of what our participants were telling us. And so to get past first the what do you need? So where are your education gaps? The providers gave us some information that we expected to hear, but there were also findings that surprised us. We knew we'd hear about hydroxyurea dosing, but we didn't expect as much to hear about mental health needs, things like that, with such a high frequency. And then tried to dig deeper into what are the systemic factors that limit your uptake of that education. So with a focus on not making assumptions about what works for us here will work there, really trying to understand that if I were to design the most comprehensive treatment or training program on sickle cell anemia and put it in place without understanding the scheduling challenges, technology constraints, the fact that if local leadership does not support the time spent engaging in that education, no matter how much the providers want it, they won't be able to utilize it, that would truly limit the impact of that education despite how much it's needed. So we really tried with our methodology and our analysis to get to those themes so that while we were not developing a theoretical framework, we were then hoping to fit those learnings into an existing platform that is evidence-based. For example, the ECHO program, to put something in place and then understand the factors that we could assist with changing so that more providers can utilize it.
Thanks. Thank you. That clarifies clearly. And it also bridges nicely, I think, to my next question, I hope, where in chapter 6, you then describe the practice and results of this actual capacity development program. So 2 questions about it. First is I wondered if and how that training needs analysis that you just elaborated on, did it inform the chapter 6 project? So maybe let's start there. Could you elaborate how those results from that training needs analysis, how it informed the design or the intervention or the research that you then present in chapter 6? Was there a relation between the two?
So there was not a direct relation between the two, and thank you for this question. The approach in the educational needs assessment was aimed to understand educational needs outside of a clinical trial context, where the training methodology that we were seeking to assess in chapter 6, and then do a thematic analysis to generate a model and a framework. In that case, the goals were slightly different. And so the TCD training was performed within a clinical trial context across multiple settings. And we were trying to get to the strategies that were effective, those that were problematic. We learned several that were unsuccessful, which also helped inform some changes along the way. And while we did in chapter 6 also try to understand the broader systemic factors, they were not so focused on limitations to training uptake. They were more focused on the training methodologies that we were trying using, adapting along the way to generate a framework that would be useful within a clinical trial, but outside of a clinical trial context as well. So they're different in that way.
Got it. Then maybe if I can take you along another context outside of that core setting where you did the research. So my context is education. I do capacity development in the area of health professions education, where I teach clinicians and teachers in institutions about how to design or deliver education. And this is also capacity development that we do. So I was wondering, could you give me some advices based on maybe the results of your projects? Are there some of those findings that are transferable across contexts that I could take on in my education capacity development work onwards?
Thank you so much for this question. There are so many things. Sometimes, as I said in the other question, sometimes it's what didn't work that helps us learn about what does. So I think definitely developing quickly and understanding that assuming what works and can be transferred quickly is something that we learned and had to adapt to. Accepting the need for problem solving is an adaptation of our approach throughout training, continually assessing we did also learn that asking those receiving the training how we're doing will not always result in an honest answer. So having different ways to measure the success and applicability of the training that doesn't involve opinions, that was something we were mindful of when performing the research in Chapter 6 and we did try to create scenarios for that mitigated that bias. I didn't do the interviews for that exact reason. I think the other very important learning has been that building leadership capacity has to go in line with building capacity for whatever tool or assessment or item that we're training on. So more broadly, helping local leaders develop their skills, develop ways to manage change in their settings, and that those leaders may not be people with a leadership title. They might be engaged parties who are committed and who are strong and who want to be part of change, but may not have the tools themselves to manage that. So that's almost a soft skill or approach to it, but at the same time, I think it's a huge opportunity to transfer knowledge in a different way that builds a leadership force that can then also help build capacity for others in their settings by emulating some of those behaviors and
Thank you.
Teresa Latham, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. And I request that you and the people following the live stream await the results of our deliberations and our return.
Thank you.
Teresa Latham. The degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Chabanovska is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you very much, dear Prorector. And now we'll take the oath. Dear Teresa Smith Latham, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Teresa Smith Latham, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university shown by the beadle.
Thank you.
Beautiful. And now there is a special time for you, Teresa, and all three of your supervisors would like to give you the laudatio. We will start with Professor Wire.
Almost every day we awaken to bad stories and depressing news, but today is different. We have a good story, the successful journey of Teresa Smith Latham to achieve her PhD. Teresa, we first met in 2013. I had recently arrived at Cincinnati Children's Hospital with plans to create a global sickle cell research program, which could transfer knowledge and treatments to low-resource settings, particularly in the Caribbean and sub-Saharan Africa. I recall you were interested in helping, but had a terrible fear of flying. So you decided to work just from Cincinnati to help build the databases and to do remote monitoring. Fast forward 6 years. Teresa, you are now a frequent flyer, traveling by plane all around the world, actually leading the data coordinating center for several prospective sickle cell trials in Jamaica, Dominican Republic, and 5 countries in sub-Saharan Africa. You are also helping design projects. But despite the success, you realized that more formal and rigorous training would allow you to have an even greater impact. You began to think about doctoral programs for a terminal degree just as COVID arrived. Fortunately, you found the Indiana University program in public health led by Dean Sue Babbage and matriculated there in August 2021. And despite COVID, you had great experiences there and were extremely successful, culminating with your doctorate of public health in May 2024. At Indiana, you also learned about the possibility of even more rigor through the PhD program at Maastricht University. I recall you saying that no one from the Indiana program had yet accomplished this, so of course you took on this additional challenge. Over the past 24 months, I believe you have become more focused, more efficient, and more skilled. You have also learned so much from Maastricht, and especially from Professor Kasia Chabanowska. Now today we celebrate your many successes, but especially your newly minted PhD. Teresa Latham, PhD. You have been well supported by your parents and family, plus dozens of colleagues here at Cincinnati Children's Hospital. Together, we are all incredibly proud of your accomplishments and see great potential as you use your formal training to do even greater things. From my personal viewpoint, I see only brighter days and bigger projects. As you like to say, wheels up. Congratulations and Godspeed for the next steps.
Thank you very much, Professor Ware, for the laudatio. And now I would like to ask Professor Sue Babbage.
Thank you. Thank you so much. It is indeed a pleasure and a privilege to add a few words to this wonderful story, Russell, that we've just heard about Teresa's remarkable journey. Teresa, I first met you when you reached out to me with interest in joining the doctoral program in public health at Indiana University in Indianapolis. From our very first conversation, it was clear that Teresa was already a dedicated researcher, deeply engaged in her work at Cincinnati Children's Hospital. But what struck me most was not only her commitment to research, but it was her vision. Teresa was thinking about the future, about leading research teams, mentoring others, and expanding her impact in global health. Our Indiana University program focuses on leadership development, and Teresa clearly belonged there. But because of her strong research orientation, we suggested something a little unusual. And at the time, we had just begun a new partnership with Maastricht University, an opportunity for exceptional students to build on their DRPH training and pursue a complementary PhD program. This was a new pathway, untested, and Teresa would be the first to try it. Teresa, to your great credit, you did not hesitate. It takes courage and ambition to become the test case for something new, to trust the process, to step into uncertainty, and to commit to the long journey of two demanding doctoral programs. And Teresa did just that. She completed the DRPH with distinction, and then she carried that momentum forward into the PhD program that she completes today. Throughout these years, I have seen, Teresa, in you a consistent commitment to excellence in research, but also something equally important, a genuine aspiration to lead and to collaborate, to mentor others in the work of improving health around the world. Teresa, it has truly been a pleasure working with you over these years and watching your growth, both as a scholar and a leader. I have every expectation that this achievement is only one milestone in a career that will have significant impact on research, on patients, and on the colleagues that you will guide along the way. Congratulations, Dr. Teresa Latham. We are very proud of you, and we wish you every success in the exciting chapters that lie ahead. Thank you, Professor Chabanowska.
Thank you very much. And as you see, the story is unfolding. And now it's my turn, Dr. Latham, with the 2 degrees. Dear Teresa, I feel so privileged to give this laudatio to acknowledge your scientific achievement of this PhD degree from Maastricht University. We are so grateful that we could accompany you throughout this academic journey because you let us be with you. And we noticed that you are a dedicated scientist, a dedicated scholar with a great vision. When we travel together, we recognize and admire certain qualities and talents which shine and make you special. And in your case, it was great responsibility, courage to aim high, a great trust that you build in us as your supervisors, that you will reach your aim, academic curiosity and passion, scientific development with a very big picture, and great ability to act on feedback in a very constructive way that was leading you to producing great results. You have contributed meaningfully to building and strategizing the knowledge base for building capacity for sickle cell disease in all its aspects in low resource settings. We have seen you grow in the scientific leadership role, and I really agree here with Sue, who has emphasized this specific attribute that we could observe. I'm sure that you will be able to help others grow in science, especially in low resource countries. And that will happen through your humble, empathic approach, which is blended with scientific evidence-based leadership. Dear Teresa, you deliver quality achievements in public health. We are proud to walk with you the road that you have chosen that brought you here today. Congratulations to you, to your family, to your friends. And now it's a time to celebrate. Thank you. I give the voice to the prorector.
Thank you. Dear Dr. Latham, also on behalf of Maastricht University, I would like to congratulate you with the degree you have acquired. I also like to congratulate your family, friends, colleagues who, one way or the other, have helped you in this journey to reach this final destination. I'd like to congratulate your supervisors from Maastricht and from the United States. Congratulations with this really beautiful defense. Maybe I can say a little bit about the opinion of the degree committee, because you heard the opinion of your supervisors, but also the degree committee was very much impressed by your thesis and the quality of your defense. You have really shown that you're on top of the topic, and it's a pity we weren't able to do this ceremony live, but I hope you enjoyed the discussions with the degree committee, and I really hope that you will continue this research on a very important topic, and that will help to improve the care for children with sickle cell anemia in low resource settings. I think this is the end of the academic ceremony, and I close the ceremony. Now there is some time for the degree committee and the other people present to congratulate you, and I first give the word to Professor Ten Katen.
Thank you very much. Well, Dr.